Welcome back, everyone. My name is Stephen Schuler. I'm the secretary for the Society of Digital Mental Health, and on behalf of the board and also the organizing group, I really want to just thank everyone for joining us for the second day of our inaugural conference for the Society for Digital Mental Health. I want to comment on a little bit on some of the themes that we heard yesterday and some of the things that I think will continue to be carried on to day 2 of our meeting here. We felt like we had some really great conversations, a great keynote from Tanzim Chouhardri, a fantastic panel, and really appreciated people's willingness to join us in those breakout rooms to have a more conversation around evidence standards and digital mental health. Some of the things that we heard is that although the Society for Digital Mental Health makes a really great name for an organization, it really doesn't demonstrate that digital mental health is not a homogeneous category. There are multiple different types of interventions, different use cases for these things. And one thing that really came out in terms of the panel and the following conversations was really separating between some of the different use cases, thinking about the differences between wellness apps, prescription digital therapeutics, and digital therapeutics, and what those mean in terms of evidence standards, as well as our integration and implementation in the field. Along that, we started to have a lot of conversations in some of those groups around reimbursement, which is the theme of one of our panels for later today. Another thing that came up a lot was discussions of issues of diversity, equity, and inclusion. How do we build digital mental health interventions and evaluate digital mental health interventions to make sure that they truly are accessible and available to those who have traditionally been underserved by our current mental health system? And really centering the evaluation, the development, and the deployment to make sure that we are not increasing inequities through the use of digital mental health. And so we want to continue that conversation as we go throughout the day today. One of the major themes of the flash talks are actually focused on different ways in which digital mental health interventions can expand access and accessibility for a variety of different people. I also want to note, going back to this theme around this heterogeneous nature of digital mental health, that this is a really heterogeneous group of folks who are coming together in this virtual meeting. I hope you got a taste of that in the breakout sessions. And I think that you'll see that again in the flash talks. I know it's a little bit harder sometimes to interact with people in these virtual environments. And so we've been trying out some different modes of interaction that will help facilitate that. But I just want to note that as of our last count, and it's continuing to grow, we had 457 registrants to this meeting. 8% of those registrants were in clinical care, 10% were in industry, and about another 10%, the different buckets we gave you to classify yourself were not sufficient to even classify your role. And so I do think we are seeing a heterogeneous group of folks coming together, which is really a goal of the Society for Digital Mental Health. So before we get started with our kickoff keynote for today, I just want to note a couple of things. One, just remember, if you haven't joined, please become a member. Membership is free, and it would be really great to see this diverse group of individuals who are interested in this space be part of the membership so we can stay connected. Also share information is follow-ups from our meeting, as well as letting you know when the recordings for the different sessions are available. At the end of the day today, we'll also be sharing a follow-up survey. And so please do come answer that survey. Feedback is really useful. We've already noted a couple things that we can improve and would love to hear from folks about different things that you've experienced that we could do better. And again, we really just want to thank you for your grace and patience as we navigate this inaugural virtual meeting and this virtual platform. Just want to give a quick overview of what the content will be for today. So we'll start with a keynote address. Our second keynote in this one will be from David Clark, before moving on to a panel talking about reimbursement issues in digital mental health. We have some really great panelists as part of that panel. We'll have a short break, and then we'll move into a series of 4 different concurrent flash talk sessions. So these will be short talks by variety of different individuals from the field. Please join the Flash Talk session that is most relevant to your interests. They are themed, but also feel free to jump between the different Flash Talk sessions to get a taste for it. And then we'll have a short wrap up at the end of the day by the president of the Society for Digital Mental Health, David Moore. And with that, again, I want to just thank you for joining us again today, and we'll invite Sabrina Wilhelm and David Clark into this session to kick off our keynote address.
Hello, I'm Sabrina Wilhelm, and I'm on the board of the Society for Digital Mental Health. And today I have the pleasure to introduce David Clark. And David is someone I've known for a really long time, for over 20 years. And David, we were just so thrilled when you agreed to speak today. So David is professor of experimental psychology at the University of Oxford, and his work has had a major impact on our understanding of the psychological treatments for anxiety disorders, especially panic disorder and social anxiety disorder, health anxiety, and PTSD. And most relevant for this conference, David has successfully developed and evaluated online versions of social anxiety and PTSD treatments. And David is also really well known for finding solutions to the challenges of how we might best disseminate effective psychological treatments within the healthcare systems. And he's actually one of the architects of the very impressive Improving Access to Psychological Therapies, or IAPT program. That's a really impressive British program that we will be hearing about today. David has won many, many awards for his groundbreaking work, including the Lifetime Achievement Awards from both the British as well as the American Psychological Associations. And today we are very, very fortunate that David will speak on how we might use digital tools in the English IAP program. And while David speaks, please feel free to use a little chat feature to post your questions, and we'll discuss them after David's presentation. And now it's my pleasure to turn things over to David.
Thank you so much, Sabine, for such a kind introduction. And it's lovely to join you all today in this sort of virtual world. Let me just do a screen share. So hopefully you can see my slides. So as Sabine said, I'm going to be talking about the evolving use of digital in the English Improving Access to Psychological Therapies, shorthand IAPT program. And so I'll start by telling you what that program is, and then look at how we're looking to digital in various means to try and enhance the program. So the IAP program was created to try and deal with a major injustice. Research, largely from psychological treatments, has really got us to a point when there are new prospects for the mental health treatment of many people. In England, we have a government body called NICE, the National Institute for Care and Clinical Excellence, which is an impartial body charged by the government to look at the evidence for the effectiveness of interventions across the whole of medicine. And when it feels there is good evidence that something works, to then issue a recommendation for it to be used in the health service. And over the last 15 years, NICE has been issuing guidelines on the treatment of mental health problems, and they are very clear in stating that certain evidence-based short-term psychological therapies, such as CBT, but also for depression, some other therapies like interpersonal therapy and brief psychodynamic therapy, should be considered first-line interventions for common mental health problems like depression and all the anxiety disorders. And surveys show that this is a recommendation that's popular with the public. So there are over 30 of these surveys, and they always find that there are some people, when you ask them, would you prefer psychological therapy or medication, you say, please give me the tablets. But in a ratio of 3 to 1, people say they would prefer an evidence-based psychological therapy. And people don't get what they want. In England, the situation was really bad before the program I'm about to tell you about. So back in 2007, when it started, less than 5% of adults in the UK with anxiety or depression were getting an evidence-based psychological therapy. A few more were getting some therapies that hadn't got an evidence base, but the majority of people either got no treatment or medication. And the waits to start treatment were just appalling, on average over a year. And while this is a bad situation in the UK, I think it's fair to say that there was no other country anywhere in the world where the public was getting what it wanted either. There isn't nowhere where psychological treatments are more widely available than medication. And this is a terrible injustice for people with mental health problems. So the IAPT program was created as a partial solution to that. I say partial solution because it's far from finished. It's still growing. But the aim was to make evidence-based psychological treatments much more widely available by training a large number, it's currently 9,800, psychological therapists using good evidence-based training curricula, checking that they develop the competencies required to deliver the treatments well, and then deploying them in what we call step care psychological therapy services for depression and anxiety. I think many of you will know what the concept of step care is. It's the idea that, at least for people with the more mild to moderate symptoms, many people can benefit from something which has a relatively low amount of therapist input, such as guided self-help, of course now computerized CBT. But for those people who don't benefit from that, or who start with more severe symptoms, then they would go straight to more conventional high-intensity therapy, such as CBT. And for those people who start at low intensity, many recover. Those who don't, though, would be promptly stepped up to the high-intensity intervention. So we're talking about a system of care, not a single treatment. This was going to be expensive. And so the government wanted to know whether people got the benefits that were promised. So a key bit of the program is to try to measure and report the clinical outcomes of every single patient who has a course of treatment in IAPT. So, and we call a course of treatment at least 2 sessions. It's sort of like more of an intention to treat analysis. So you include anyone who drops out after that as well. This, in a sense, is a unique exercise in public transparency, because the results of all the IAPT services are published every month on a public website. The whole program was based on what we considered to be sound economic and clinical arguments. And what persuaded the government was a combined economic argument presented by my colleague, Richard Layard, and I, which, if you're interested in reading more about it, you can see that in our book, Thrive, How Better Mental Health Care Transforms Lives and Saves Money. But basically, it said that if you deliver these treatments well, on average up to about 10 sessions, then the cost of delivery will be more than covered by the savings you make in other healthcare costs, and also benefits to the economy in terms of people getting back into work, being more productive in work. So the argument was, when money is short, and it certainly is in most world economies at the moment, then it's idiocy not to do this, because it saves you money, it doesn't cost you money. So the IAP program was started back in 2008. It started quite small in the first year, only a small number of people were seen, but it's gradually grown over the years to a point where now over 1 million people access the services every year. And not everyone has a course of treatment. After the assessment, some people just need some simple advice, or maybe the problem isn't depression or anxiety, they need referring elsewhere. But about 640,000 people need a course of treatment and get it. Waiting times have gone down from over a year to just 20 days on average. And using a session-by-session outcome monitoring system, we are able to collect pre and post-treatment measures of anxiety and depression on 99.2% of that 640,000 people. So we have a complete data set. And what we find is that the clinical outcomes that we're achieving now are broadly in line with what we'd expect from the research literature. So I told the government back in 2007 that if we deliver the latest treatments well, we should get about 50% of everyone that we treat to recover. By that, we meant they were no longer in the clinical range on either depression or anxiety. It's a joint recovery criterion. And we thought about 70% of people would show, worthwhile, substantial benefit. And this is the outcomes year by year for the program. And you can see that this was an overambitious initial promise. We fell quite a lot short of that. And it took us several years until we got to our target, but we've been there ever since for the last 7 years. And you can see we're pretty close to the 70% improvement rate as well. And it's attracted a lot of positive attention. Nature very kindly called it world beating, and a review of the Canadian healthcare system recently, surprisingly, started off with a headline, "For better mental health care in Canada, look to Britain." And it was talking about the IAP program. So what's been going on here? How have we managed to improve the outcomes so much over the years? Well, it's really that data. It's having a complete data set and learning from it. We found that some services were much more effective than others early on. So we studied what the differences were. We find that some interventions are much more effective than others, and we study the differences, and we feed that information back into the system with an evolving, constantly updated manual called the IAPT Manual, which you can access if you want from this website. And this shows the sort of how the feedback process works. So here is the sort of annual recovery rate, the black dotted lines over a 5-year period. And then what I've put here is the lowest performing services, the bottom 10%. And you can see with this sort of feedback and evolution, they've improved their performance enormously. The top performers stay top performers and haven't changed a lot. But the consequence is the variability in outcomes between the worst and the best has more or less halved from about 20 percentage points to about 10. The manual will show you a lot of the discoveries. I don't have time to tell you all of them, but I want to mention a few because I'm going to pick them up again in the digital section. So one of the things we found quite early on is it actually is important to follow clinical guidelines. We did have a fair number of therapists who were giving non-NICE recommended treatments early on, and we found they got less good results. We also find that those services that do best in terms of outcomes are very good at quickly identifying what the key problem is that they need to be treating. They have, on average, quite low waiting times to start treatment, less than 6 weeks. This graph here shows, this is blue dots is all the patients treated in a service in a year. So about 5,000 patients per blue dot. And this is the average number of days people in that service have to wait before starting treatment. And then that's their chance of being reliably improved at the end of their treatment. All these services are ostensibly given the same treatments, but you see, if you don't get started fairly early on, your chance of recovery has dropped quite a bit. So the government now asks us to try and start treatment within 6 weeks. But we also found that services that use step care well, if you don't respond at the low intensity, we step you up promptly, do a lot better. And also services that manage to keep the sort of do not attend rate, in patients not turning up for appointments and not telling you about it, also do better. So IAP was really started before digital therapies really got going in any scale. And so they weren't part of the original program. But of course, digital therapy is the biggest research area in psychotherapy, and lots of progress has been made. So of course, the IAP program wants to make use of digital developments as much as possible. And I'm just going to outline a few ways in which this is starting to happen. It obviously needs to go much further, but it's very encouraging. So firstly, you notice that one of the key things was identifying the problems that need treatment right at the start and getting people to the right treatment quickly. So in order to improve that, we now have sort of online engagement with a number of IAP services where people will log on and they'll find out what would happen in treatment if they enter the service. And they're also asked quite a lot of screening questions, which are passed on to the service. So the service is already ahead of itself in terms of its initial assessment. And the assessor, when they have an assessment appointment, can ask probing questions to just make sure they get the sort of clarity about the problems needed treating. Also, we want to use this to reduce the waiting time to get going. And so we're introducing a sort of choose and book system where once you've decided you'd like to be referred into the IAP service, you can choose a vacant slot and book yourself in straight away, not waiting for a reply from the service. And then as you go through therapy, people can get sent SMS reminders of their appointments, and we find that really reduces DNA rates. We want to use digital devices as much as possible to reduce the burden for data entry, because the data is so critical to us. And so we've evolved to use smartphone entry of the key outcome measures, such as the PHQ for depression, a GAD for generalized anxiety, and some other rather specific anxiety measures, such as the SPIN for social anxiety. And that makes it easier for patients to input their data. It also automatically goes into the IT system of the service. And when a therapist sees a patient, they can see the graphs of all of these things up on their screen. They can share them with the patient. So there's no sort of wasted clinical time with data entry. One of the reasons why people are interested in psychological treatments rather than medication is because they tend to have better long-term outcomes, because people learn new skills to deal with psychological problems, whereas when you stop taking your tablet, it's out of your system. But we've found that commissioners in England are not keen to pay for follow-up appointments, which is a shame, because we want to monitor how well people stay in the long term. And if people show a sign of a bit of a relapse, we want to get in early, give them maybe a modest booster to nip things in the bud. So we're developing an app, a phone app, which people start to use in therapy, which give them lots of extra resources, ways of recording homework assignments and things, so they're used to it. But then when they finish therapy, it will ping them once a month, prompting them to fill in their mood measures, so we can see any signs of clinical deterioration and help intervene quickly. That seems a way of getting around the problem that commissioners are not willing to pay routinely for these in-person follow-ups, but the app can get around that, we hope. And of course, we want to use digital interventions as much as possible. And I'm going to talk about 3 classes briefly. So obviously, one of them is remote delivery of live therapy sessions. And that happens through typing with the IESO product that I think many of you will know, and that's been deployed in a number of IAP services. And the subset of patients who like that mode of interacting are doing well with it. But also COVID, as you'll see in a moment, has really made us use video conferencing much more. And we've learned a lot about how to do that. And it's been an enormous, strange, silver lining of the pandemic. We also already have some therapist-assisted internet programs. As we have a large therapy workforce, we have the workforce to do the therapist assistance, as long as we have online programs that are appropriately effective. And I'll say a bit about that. And we're also starting to look at using virtual reality in the services as well. So I suppose if we're talking about remote delivery, this horrible thing here has taught us an awful lot. So you won't be surprised to hear that the IAP program was not included in anyone's English pandemic planning. And when the nation suddenly shut down on the 23rd of March 2020 and we're all sent home, there was about a 24-hour debate. What do we do with the IAP program? Because people couldn't come in for therapy. There was some suggestion maybe the therapist should just be deployed to inpatient wards because there are a lot of staff going to go off sick as well. But then, some of us pointed out, yes, but IAP deals with the most common mental health problems. It deals with exactly the problems that are going to be increased most by a pandemic. So it was agreed that instead we would move the whole operation to remote delivery. The therapists would go home. Vast numbers of laptops were suddenly produced in a period of a couple of weeks, and people were asked to deliver therapy from their own home into the home of their patients. This wasn't something that was happening much up to that point. And in a sort of moment of national crisis, my own research team just stopped what it was doing in its own research for 2 months and just helped to try and train our workforce. We did quite a lot of large webinars, up to nearly 2,000 people in each webinar, training them on how to do remote delivery of PTSD treatment, social anxiety treatment, panic treatment, and other people did the same for a number of the other clinical conditions in IAPT. And we were moving into completely unknown territory. But luckily, we were still collecting all the data, particularly with the phone apps. So we could see, what happens when we move into this unknown territory. And I'm really pleased to say that we managed to keep on treating just as many people as we did pre-pandemic, actually slightly more. And after a small blip in the first month, as people moved all their equipment home, our outcomes were maintained, and we stayed above that 50% recovery rate throughout the pandemic, which was extraordinarily encouraging and an amazing testament to the incredibly dedicated workforce of around about 10,000 therapists who are in IAPT. If you want to see a bit more about the resources that we've made available to people to do remote delivery, you'll see them on our free therapist resources website called Oxcadet Resources. If you just Google it, you will get it. And if you log in as a clinician, as you register a clinician, you get access to all the materials. There is no cost whatsoever. You will see a lot of clinical workshops. You'll see a lot of video illustrations of different ways of treating all the conditions that our group works on. But you will also see quite a lot of resources about how to deliver therapy through video links and some manuals about how to do that. So please use it as you wish. We currently have therapists in 139 countries using it at the moment. So what was this shift in the way we deliver the treatments? Well, this sort of illustrates it from the month before the lockdown and then the next year. So you can see face-to-face therapy was the majority, about 64% pre-pandemic, and a fair amount of telephone delivery of guided self-help, at least. Very little video delivery, and this is the sort of internet online treatment predominantly. All of a sudden, the face-to-face just collapses. We use the telephone much more for the people who are trained, but the biggest increase you can see is in the video delivery, up by over 1,000%. And we were just really thrilled that we could get essentially the same outcomes by doing that. But we're now, of course, starting to return to the clinic. And we've also been interviewing a lot of people who went through the video therapy and some people who refused it. And some people refused it because they thought, maybe it's not going to be long, the pandemic, and I'd really like face-to-face. Other people refused it because they didn't feel safe in their own homes. They hadn't got somewhere where they could confidentially have a therapy session. So that wasn't going to work. And a survey of people who had the internet therapy, the video therapy, asking them, if you developed a mental health problem in the future and you'd had a choice between face-to-face and video, what would you prefer? a lot of them said, well, I got better with the video, but I would like next time for it to be face-to-face. So it's a bit mixed, and it's also mixed in terms of the therapist's experience. So it gives a more flexible way of working, a lot more working from home, which quite a lot of people like. But of course, you miss quite a lot of support from your colleagues. You miss those sort of social interactions at work. And it's a bit more difficult to do really good quality clinical supervision. So going forward, video delivery is going to be a much more prominent part of the IAP program, but it has to be a matter of patient choice. So in order to guarantee that this is the case, the English Department of Health will monitor very closely the waiting times to start face-to-face treatment versus remote delivered treatment, and will require all services to ensure that you don't have to wait longer for face-to-face therapy than remote delivery, so that it is a genuine patient choice. People are not being forced to go for one just because they can start treatment more quickly. So the next thing I'd like to talk about, of course, is internet therapies, and I think probably everyone on the call knows quite a lot about them. They are, the biggest growth area in research in psychotherapy. And of course, the point here is that the key skills in therapies such as CBT can be presented in online modules that patients can access from home 24 hours a day. And then for getting the best results, usually you need some therapist support, often asynchronous through messaging or short video calls and phone calls. And the literature certainly shows that some of these internet therapies can be as effective as face-to-face therapy. And they may have the benefit of also requiring less therapist time, as well as being more flexible. So we are bringing a number of those internet therapies into the IAP program. The one which has the biggest penetration at the moment is Silver Cloud's Space for Depression intervention, which in many ways is a computerized version of guided self-help. And that's really in very wide use in IAP services and is being very beneficial. But other internet therapies are becoming potentially available and are likely to be picked up with time. And I thought, because Sabine kindly mentioned that our research group has been involved a bit in developing internet therapies, that I'd tell you briefly a bit about one of our internet therapies. So NICE does not recommend low intensity interventions for social anxiety disorder. It doesn't recommend guided self-help, for example. It says you should go to high intensity CBT because the evidence base for it is stronger. And a fairly specialized form, which often involves video feedback and some work on trauma memories and things like that, which is not a terribly easy treatment to deliver. But the outcomes are very good in the face-to-face therapy. It's been shown to be better than interpersonal therapy, psychodynamic psychotherapy, multiple comparisons against medication, and also than standard CBT like group CBT. So we've wondered, but it takes quite a bit of time, about 18 hours of therapy. So recently we've been developing an internet version of the treatment, which puts all of the key features in the internet program. It has a secure video conferencing feature in it with recording in it, so that you can, for example, do video feedback of social interactions that people have within the program. We've compared it firstly in a randomized control trial against the face-to-face therapy, both of them given by our experts, so really leading people. That's a trial which will come out in Psychological Medicine in a few weeks' time. You can see the sort of headline result here, that if you take the face-to-face therapy, you do need the 18 hours. You can see this is the Leibovitz social anxiety scale. For each extra hour of therapy on average, you're getting some extra benefit. So you can't really skimp on that in the face-to-face therapy. But if you use the internet therapy, then you can see you get to the same point much earlier, after much less therapist time. You only after just 6.5 hours rather than 18 hours. And the sort of recovery rates you get if you're looking at the IAPT rather strict recovery measure of no longer meeting symptomatic criteria for social anxiety or depression. It's 63% recovery. If you're looking at loss of diagnosis of social anxiety alone, it's quite a bit higher. So it's a strict requirement. And the reliably improved rate is 84%. One of the nice things about internet therapies is if you get the content right, of course, it can travel all over the world. So we've recently done a trial in Hong Kong, which will appear shortly in Internet Interventions, where we find the same program with a Chinese population who are reading it in English, but all the therapist support is in Cantonese, does at least as well, 68% recovery and 82% improved. What we've been doing recently then is saying, well, you know, if you move outside of the rarefied atmosphere of a well-funded randomized control trial, what happens if you deliver it in the clinical services? So we've been training up therapists in 6 IAPT services to deliver the treatment. We've, I guess, treated about 250 people so far that way. And we're finding that we're getting essentially the same results, which is really encouraging. So 60% recovery, 81% reliably improved. And I should say that this is quite a bit better than the existing outcomes for non-digital therapy in IAPT, where in social anxiety, it's more like 40% recovery. And of course, it's not just about getting over your symptoms, it's also about whether you feel your life has changed. And so we ask people a question at the end of therapy: do you feel more or less able to live the life you would like to live? And it's really encouraging that in this trial, 91% of patients said, yes, they do feel more able to live the life they would like. So that's just an illustration of some of the evolving internet therapies. As Sabine mentioned, we're also have one for PTSD, where we've just finished a trial comparing it against an alternative internet treatment, so looking at very specific events. But another aspect of digital delivery is, of course, virtual reality, and we are exploring using that to help people overcome their fears. And this is an illustration of someone with a height phobia in a shopping mall before treatment, finding it very difficult to get even to overlook the balcony at the first floor. And now he's going through the virtual reality program. And as you can see, very happily looking over the edge now.
This would have been simply impossible 3 months ago. That it would have been total avoidance. I wouldn't even have attempted this.
So at that last bit, I should mention, he's standing on a glass bridge at the top of the shopping center. And you can see, you know, really benefiting a lot with really quite a small amount of virtual reality input. So this, I think, will be something we'll see more of as time goes on. So to wind up, we are looking to use digital interventions much more widely in IAPT. Given the nature of the IAPT program, we have particular expectations about them. IAPT really delivers NICE recommended treatment. So the programs do have to have the content of a NICE recommended treatment. They obviously have to have the right data security for the NHS. And I think you'll have heard from Tanzim's keynote yesterday that one of the big issues is to make sure you get proper clinical integration with your existing system. So in our case, that means we want the programs to collect the IAPT data set and to link into the IAPT IT systems in an automated way. We need some convenient clinician interface so that clinicians can manage a lot of patients within a program easily. And we need the interventions to be part of our integrated care system. So they can move in parallel with some of the other things that are happening. For example, Sleepio has recently been recommended by NICE, actually, and that's not therapy assisted, and it's quite likely that some patients who are going through depression treatment may at the same time be running through a Sleepio program, because we know if we can improve people's sleep, it improves their mood. But a key thing with all of these interventions will, of course, be the outcomes that they achieve. So IAP services are expected to get at least 50% of people to recover. So they were always going to be looking, if you've got a digital intervention, to see that it is at least as good as the non-digital interventions. And I should say that the measurement we use is what we call a SMART metric. So to quickly talk you through that, if, say, you treat 100 patients and you only get data on 500 of them and 250 of them recovered, then you would say in the routine system, which is used in a lot of healthcare systems, 50% recovery. But IAP doesn't do that. It would say in this case, you've only got 25% recovery, because if you don't demonstrate that someone gets better, we assume they didn't. So what that means is if you have a program which has a lot of people dropping out early on, it will always look bad in IAP metrics. So it's very important that all of our digital interventions are very engaging so we don't lose people early on. And this sort of outcome will be publicly available. So we, in the IAP dataset, code each of the digital interventions that are being used, and each month as time goes on, the public will see the outcomes associated with each of the internet treatments and how many people are treated. For information, currently about 58,000 sessions of internet therapy are offered each month, which is about 10% of the total number of sessions in IAP. So I'd like to say thank you so much for listening, and I look forward to questions.
Thank you so much, David. This was such an important talk, and I really hope that other countries and health systems will follow your example. So we have many questions, so I'll just jump right in. There were a number of questions about cost savings and the economics. People were wondering whether the actual economics actually met with the projected economics and whether you had actually published on that.
Yeah, so we think they do broadly. So the first question was, is the cost of therapy what we estimated? And we estimated it's about £700 per patient, and I think it's 720 is the average. So we got that right. If you look at cost savings, then the IAP data set doesn't, it collects data on employment. So we can see that more people are moving into employment, which is good. It doesn't routinely collect data on other healthcare usages, but we have, as part of some special initiatives, done that. So, for example, we've been launching a version of the IAP services which focuses on people with also long-term physical health conditions. And we have shown that those people who come into therapy in IAPT who've got long-term physical health conditions like diabetes, cardiovascular disease and things, we do make the savings that we predicted. So, for example, we find in the first 3 months of people's involvement in IAPT, we're saving an average of £380 per patient, which I guess is what, $450 per patient on their other physical healthcare costs. That's half of the cost of therapy already.
That's incredible. And is that published somewhere? Because I think if people,
yes.
Okay, where would that be, David?
Yeah, so there's I'll probably put it in the chat because there are 2 recent publications on it. Yeah, one's by Tofaluti in 2022 and the other is by Gruber in 2022.
Oh, thank you. Yeah, that will be really helpful for people to know if they want to argue for a similar system in their own country. So
yeah, I think that's right, because my experience is that when you're dealing with politicians, and we were dealing with the Prime Minister initially, Tony Blair, then actually it's very clear that the Treasury runs your countries, and that the argument you make is an economic one. When that's won, of course, the political announcement will be very much more about it's really good to do these things and help mental health, but you have to get the economics right first.
Yeah, it's interesting that you say this. That came up yesterday in one of the breakout sessions also, as people were starting to disseminate their digital tools in various healthcare systems, that they were learning to not only focus on symptom reduction and improvement in functioning, but also focusing on cost, right? And return on investment. If a health insurance company buys your app, what do they actually save? So that's a very important point that we don't always think about. Okay, so there are other questions here as well. Yeah, there was quite a discussion in the chat about people who waited longer for treatment to start got worse outcomes, right? So, and there were a whole number of different theories proposed why that might be. But do you have any insights why that might be?
So the graph I showed didn't show that individuals who waited longer got poorer outcomes. It was a graph that was looking at the overall performance of a whole service. And it was saying if, on average, people wait longer in that service than in another service, then the service gets poorer outcomes. This is really quite an important point, because I think if you are looking at individual patient data, it would be pretty difficult to interpret, wouldn't it? Because there might be good reasons why people had to wait longer. Maybe they kept on cancelling their initial appointments and things, and then maybe they're not a good candidate for therapy. So if you did it as an individual patient analysis, I think it's very difficult to interpret. But if you're doing it as a whole service analysis, then, on average, you're seeing similar populations coming into all these different services. So I think it really is a function of the wait. Does that make sense?
Yeah, absolutely, actually. And so you talked quite a bit about adults, and there were some questions about similar services for children as well.
Yes. Yeah, good. So yes, so we are just starting, well, it's not just starting, I guess we've been doing it for about 5 years, a schools-based version of IAPT, where young people could get therapy in their school or near to their school. That seems to be doing well. We're in, I think, about 30% of English schools at the moment, and they're using the similar session-by-session outcome monitoring system. They haven't yet got to the sort of 99% paired data completeness that we have in the adult program, but it's at 70% now. Peter Fonagy is running that, and the outcomes are looking good. And the government is committed to further expanding it. I think by the end of this parliament, the plan is 40% of schools. Obviously, I would like 100%, and obviously we'll be lobbying for a long time to ensure we get there.
Yeah, and unfortunately we are out of time. There are still some questions left, but unfortunately we won't be able to cover them. Maybe we can cover them later in the chat lobby or so. But thank you again, David, for a fantastic presentation. And as you can see in the chat, people are also commenting on how much they liked it. So thank you very much. And I hope to see you all in the panel. So you need to go back to the main page and then you can log into our panel. Thanks, everybody.
Bye.